All right. Good morning, everyone. It is time for rounds on this Wednesday, January 8th. All right. I am Gillian Shaw, and I'm one of the pathologists here in Coplow, and I'm going to go ahead and get started. So the first case I have to show is an eye from a 5-year-old Labrador Retriever mixed dog. And the history we got was that on November 30th, this dog had a 5-day history of blepharospasm in the right eye and a ventral nasal cataract, plus or minus a lens abscess. In the same tract, they also noted an iris abscess and a punctate corneal opacity. And then about, maybe 13 days later, the dog had iris bombay with extension of white lens opacity into the anterior chamber. 2 out of 4 flare, 3 out of 4 cellular flare, a narrow anterior chamber, ventral nasal vascular membrane from the iris margin over the lens capsule. Anyway, so here is a nice clinical photo from this clinician, which was beautiful. So what we can see is that beautiful cataract that they described, as well as that material that's sort of extending into the anterior chamber. You can see this little blob here is right in front of the iris. And so I actually spoke to this clinician beforehand, and there was concern for an infectious organism. And so I made sure to request that whoever grossed this globe took a picture of it grossly. So we got a nice picture of it. So here's the globe hemisected. The cornea is always at the top. There is some translucent gel in the anterior chamber. Here's the lens. The vitreous itself is a little bit hazy. There's a little bit of hemorrhage here and there. The retina seems to be in the correct position. And up here, you might be able to appreciate that bowing forward of this iris and its attachment to the lens right here. So this is that nice illustration of iris bombay. And it's kind of similar on the other side as well. When you look at the lens, most of it is fairly transparent, which is normal, but you might be able to appreciate a small opacity here. So at this point, we will go right to the slides. And I got multiple deeper sections of this one, and I think in the interest of time, I will not show every single one, but maybe a bunch of them. So here's our subgross view. There's the cornea. Here's the pink material in the anterior chamber. Here's that iris leaflet that's kind of adhered to the anterior lens capsule. Over here, it's similar. We have a big cover slip scratch, which may have happened this morning when I dropped everything and broke several of the slides. But anyway, here's that proteinaceous material that's in the vitreous. A little bit of red blood cells here and there. But other than that, retina looks relatively okay at this magnification. We did not sample the optic nerve head in this section, but we got it in another one. And so let's go ahead and get started at higher mag with this one. And then I'll show you some of the others at just higher mag. So we'll start over here. Here is the iris, and this is the ciliary body. Here's the peripheral cornea. We have some increased cellularity in the uveal stroma here. And when we go higher mag, this is an accumulation of lymphocytes and plasma cells. So nothing too scary going on here. We've got our plasma cells with their perinuclear clearing, and then probably there are some lymphocytes around that have a lot less cytoplasm, maybe this guy right here. So we have a lymphoplasmacytic anterior uveitis. Let's move over to the anterior chamber. So here's that proteinaceous material, and there are some cells floating around in it, which the clinician noted clinically. So these are mostly neutrophils in this area, maybe a few macrophages here and there as well. So we've got a little bit of an endophthalmitis. That is when you have inflammatory cells in the ocular chambers. When we move back to the lens, here is our lens. Here's our anterior lens capsule, which is thicker than the posterior. That's why we know this lens is properly positioned. There is some convincing syneciation or attachment of the iris, the pupillary margin of the iris to the lens capsule here. Well, there's a space here, which is an artifact, but and then when we move back into the lens, you start to pick up this material, and it's fairly extensive. And when we go higher mag, this is actually bacteria, or what I think is bacteria. So these are like giant lobulated coalescing colonies of bacteria. It doesn't come in all that well here, or show up all that well, I should say. And interestingly, at this at this level, we don't have a break in the lens capsule, and there are also no inflammatory cells associated with this material. In addition to that, the lens material around the lens fibers around these bacterial colonies are relatively unexcited about what's going on there. So there isn't really cataractous degeneration in this area. Sorry, the section is a bit wrinkled, so I have to focus up and down. When we look right here, there is actually a defect in the lens capsule, but it's not full thickness in this at this level. The rest of the eye is fairly not exciting, so I will go to one of the deeper sections. I'll go to the deepest section, which unfortunately there's a lot of artifact in the lens, which is relatively common. Sectioning artifact, that is. But what we can see is here's this plume of increased cellularity, and also the lens capsule, you can kind of follow it along here, is suddenly discontinuous here. And there's also a lot of basophilia and cellular stuff that's actually inside the lens. So here we are. These are degenerate lens fibers known as Morgagnian globules. That's one of the hallmark features of cataractous degeneration in the lens, histologically speaking. And then we also have a bunch of both viable and degenerate neutrophils here. And you can see that those neutrophils are mingling with the degenerate lens fibers in this area. Let's go. And all of these, sorry, little like club-like branching, slightly more purplish stuff is bacteria. Normally, bacteria should stain fairly darkly purple with an hematoxylin and eosin stain, which is what we're looking at. Dr. Megan Klymans, who I showed this case to a couple times, said, well, I wonder if those bacteria are actually dead, and that's why they're not looking quite normal, quote unquote, as dark as they should be with H&E. So the clinician was initially concerned about E. caniculi in this case. And E. caniculi can affect dogs, but it's very rare. So I was a bit skeptical when she mentioned this suspicion. And when she described what she was seeing clinically on the phone, I said, oh, that sounds a lot like what we call septic implantation syndrome, which is where you have penetrating traumatic injury to the lens that implants bacteria directly into the lens. And then often the bacteria will go and grow and takes a while. Sometimes it can be weeks, months, even up to a year or more for the bacteria to finally get to sort of this threshold when there's like a really severe inflammatory reaction and more of like sort of an explosion of inflammation inside the eye. So I was more skeptical of septic implantation syndrome, if nothing else, just because of the how rare E. caniculi is in dogs. So here's a gram stain. So E. caniculi organisms or encephalotozoan organisms should be about 1 to 2 microns in dimension. And then they stain positively with a gram stain. Because there was some doubt and the clinician was specifically interested in this case about whether these were whether this was encephalotozoan versus bacteria. I did a gram stain. Otherwise, I would have been like, oh, this is bacteria and moved on. But anyway, so this is the gram stain. And you can see that this is unfortunately as high as we can go. You can see that some of the organisms here do stain positively with the gram stain. And I will tell you, it might be hard to appreciate here, but these are much smaller than we would expect for E. caniculi or encephalodozoan. So we did conclude that these were bacteria and gram-positive cocci. You can see their morphology a bit better through the microscope. And there was a little bit of variation in how well they stained with the gram stain. So I think Dr. Klimans was onto something when she suggested that perhaps not all of these bacteria were viable anymore. And that might be why they looked a little bit weird on H&E and are not staining diffusely similarly on the gram stain. So this was an interesting one because this case was an interesting case of septic implantation syndrome simply because of the number of organisms that we saw inside the lens and also because of how little inflammation there actually was involved, like in this eye. So it was just very surprisingly contained. I think if this had gone a little bit longer, that leakage of bacteria, probably in degenerate lens fibers into the specifically anterior chamber, would have led to a much more significant inflammatory response, and the eye would have been much more bad off looking clinically than it was. The clinician did say that the dog felt much better after she had been enucleated, so that's happy news for this patient. Anyway, so my diagnosis here are lens capsule rupture, suppurative phakitis, cataract, and intralenticular bacteria, cocci. And this is what we call septic implantation syndrome. There is also a moderate lymphoplasmacytic anterior uveitis, which I attributed to a lens-induced uveitis associated with lens degeneration. There was a preorbital fibrovascular membrane. There was also a retinitis, which I didn't show, and a papillitis, and then some glaucomatous degeneration of the retina and the optic nerve. So this was just a really interesting case to me, just based on the number of, I've never seen that many bacteria in the lens. Usually they're actually kind of hard to find. And when I saw these, I was like, whoa, that's a lot. We don't always see the penetration site in the cornea. And also I should point out and also say that we usually implicate felines in the creation of this lesion. It can happen in both dogs and cats. I think we probably have slightly more in dogs. But as you can imagine, cat claws that are sharp enough to penetrate the cornea and back and all the way into the lens are quite sharp and quite small diameter. And so the site of penetration is often very difficult to find. And also remember that cats don't poke people like Three Stooges style. They usually swipe from one side or the other. So you don't always get like anterior or corneal penetration. It could be like scleral penetration. And sometimes they reach around kind of behind the lens. So it's not always in the anterior lens capsule that we have here. So I think I've covered everything. But as I said, this can actually develop weeks to months to almost, we have a couple that are like a year or more after like a known traumatic like cat event to like the explosion of the intraocular inflammation. So pretty interesting. So if you ever have patients who you think have been swiped by a cat and have an eye lesion, definitely caution the owner that even though you might be able to control the inflammation in the short term, depending on whether they penetrated the lens, it can eventually lead to really severe intraocular inflammation and necessitating enucleation. So there we go.
So just an unrelated factoid, my 5-year-old got really into watching funny cat videos on YouTube, and a lot of them involve dogs interacting with cats. And some of them are annoyingly made for children, and they're like 45, 50 minutes long. And of those, an enormous number of scenes were dogs going face first and cats doing multiple swipes of dogs' faces. So I'm not, I think I'm not, you might think that that's an uncommon situation that will happen. I actually, after seeing that, and just, I'm not impressed that it doesn't happen more often. And as Gillian was mentioning, vast majority of them, it's side swipes. So I think it fits with a pattern of us not seeing a clear corneal penetration. And also sometimes the lens capsule rupture tend to be more equatorial to posterior, which means, if the cat claw reaches through the lateral aspect of the sclera, you get towards the posterior chamber and towards the lateral or equatorial or the backside of the lens.
Also, one of the curiosities that Dr. DeBielzig always ponders when we have these cases is like, why is it that toddler children don't get this lesion? And there are actually very, very few reports of known cat encounters of toddlers that lead to this lesion. Thankfully, we should say, thankfully. So I'm not sure what the reason is for that, because toddlers, especially when they're on their hands and knees, are coming at the world face first, just like a dog. But anyway, okay. So anyway, that was just an interesting example of that entity. All right, next case. Sorry, there's no gross photo to entertain you with, but this is, we got an eye and orbital tissue from a 5-year-old domestic short-haired cat. The history we got was very brief. They say exophthalmos, elevated third eyelid, and resistance to retropulsion. That is all we got. So we got a globe that had some stuff attached to it. And we also got multiple pieces of orbital tissue. So I grossed this one and I sectioned it so I sectioned the globe with that material stuck to it to sample with the eye, and then also sectioned in a couple of pieces of the orbital tissue. I should say that when you're grossing an eye that has a mass attached to it, it's always good to note where it is attached to the globe. And that might help you figure out if it is a tumor, might help you figure out what its origin was. In this case, I specifically noted that the mass or the stuff that was stuck to the eye was sort of deep to, but not affecting the gland of the third eyelid. So that's kind of important. It's often good to try to at least figure out if the third eyelid gland is the origin of a mass or not. And for example, if there's a mass in the orbit that is dorsolateral to the globe, then you should be thinking lacrimal gland. And it obviously would also, if you're grossing eyes, it helps to figure out your landmarks, which is a lesson for another time. Okay, so we're just going to kind of jump right to it here. If I switch us to the proper thing. All right. Okay, so here's our globe. The cornea is right there in this section. Also a few more cover slip scratches, probably from this morning's disaster. So here's the iris, here's the lens, here's the peripheral cornea, and it meets the sclera. You can see that tinctorial difference there where the sclera meets the cornea. And then as we move back a little bit, here is that material or that mass-like stuff that was stuck to the globe. From this magnification, you can see there are some darker purple areas and some lighter purple areas. And there are some little darker, more punctate stuff going on in there. Out here, we have some adipose tissue. So this is orbital adipose. In this exact section, here's the base of the gland of the third eyelid. But we didn't actually sample the rest of the third eyelid very well. The rest of the eye is actually relatively quiet. This purple stuff up here, sorry, it's out of focus, is actually some lacrimal gland, which could be the main lacrimal gland or some accessory lacrimal gland. I'm not sure. But anyway, this is the main event, as Megan Klimans likes to say. So we're going to jump in there. Okay, so from this magnification, once again, you can see there are these swaths of more purple, this pink stuff, and then there's a more well-defined punctate purple stuff going on there. As we go higher, not too much different there. But it's always good to figure out, first of all, with any kind of mass-like lesion, is this a tumor? Like, is this neoplasia, or is this actually something else? In this case, it's something else, which is probably better news for the cat. So over here, we have a whole bunch of degenerate neutrophils. And then as we move over here, this is a bunch of necrotic cells. You can almost make out their sort of ghosty little eosinophilic outlines. And then as you can start to pick up, this is what bacteria should look like on H&E, this much more vibrant dark purple. So that's as high as we can go, sadly. So these are some fairly large bacterial cocci. And yeah, so these are bacterial cocci. They're quite large. Whenever you see very large bacterial cocci, usually it's going to be staphylococcus of some sort. We don't have culture results in this case to confirm that, but we sort of assume that it's staphylococcus. I'm going to quickly show you the slide that really bit the big one on the great disaster this morning. Let's see how this is going to work. It's not. Hold on. So this is the orbital tissue that is just greatly expanded by this inflammation. And you can see from this very low magnification how numerous those bacterial colonies are and how large they are. Just more. So it's just like, and also we have like these guys. Let's go higher mag, even though it's very sad that this slide is dead. These are pyogranulomas. Might be hard to center on one, but a pyogranuloma is basically a juicy center of neutrophils, often degenerate, surrounded by layers of epithelioid macrophages. So that's what we have here. There are also a large number of eosinophils, which might not be in. Oh, okay. It's going to be hard because I broke the slide. Anyway, there's a bunch of eosinophils around. So whenever you see large colonies like this and coalescing pyogranulomas, there's a fun pathology term that is botryomycosis, which botryO refers to grape-like, and mycosis refers to fungus, but actually it's a misnomer, like as there are many of in medicine in general. But anyway, so here's the gram stain of this case of the orbital tissues. You can see all of these are the pyogranulomas. And here are some of those grape-like, maybe you could, clusters of grape-like, I should say, bacterial colonies. This very, very dark color means that they are staining positively with the gram stains. They're gram positive, and that fits nicely into our thoughts about this being some sort of staphylococcus. So this is a very unusual lesion in cats. At least I would say that we don't receive this very often. I feel like more often it's actually surprisingly an orbital fungal infection, like an actual fungal infection, as opposed to this like pseudo fungal infection that's actually bacteria. I inquired of the clinician in my comments whether there was any history of oral or nasal disease. This was ventronasally located in the orbit, or at least the piece that was still attached to the eye was ventronasal, since it was deep to the third eyelid gland. I never heard back from them, so I'm not really sure what the origin of this is. I would sort of assume that this is some sort of traumatic injury, or at least some sort of defect that developed either to the skin or to the oral cavity. And honestly, the skin would be a better bet for staphylococcus. So I don't know if this cat had some sort of penetrating injury that implanted bacteria in there, and then it took a long time to get to this stage where they actually brought the cat to the vet and then had it enucleated and really exonerated to remove all that stuff from the orbit. Luckily, with at least knowing that they're gram-positive cocci, that can sort of direct some antibacterial, antimicrobial therapy, more specifically, if the cat needed it after surgery. So here is my diagnosis. So severe pyogranulomatous lymphoplasmacytic and eosinophilic orbital cellulitis with intralesional bacterial cocci, so botryomycosis. And yeah, this is just sort of an unusual lesion. Certainly for us in Coplow, I don't know about, I feel like I associate it with mice more than anything else, but anyway, that's all I have. So next up, Dr. Miller.
All right. Good morning, everybody. Next up, this is tissue from a 4-year-old male-neutered Doberman Pinscher, who back in July of last year This was a dog that was at a rescue society, and the complaint at that time was bilaterally symmetrical conjunctival thickening. They had a suspected diagnosis, and they sent biopsies in to us, and we confirmed their diagnosis, which I will withhold until we look at the slides in a little bit. They treated the dog with multiple eye drops, including heparin, prednisolone acetate, tacrolimus, Optics Care Eye Health. The dog did not have any other systemic issues at the time of diagnosis, nor did it develop any during this treatment. Unfortunately, kind of with the long-term eye drops, the dog started to get head shy and was having a decreased quality of life and didn't seem to be gaining any interest of being adopted. So they actually ended up humanely euthanizing the dog. But they did send us both of the eyes so we could get a nice good look at this lesion. So what is up on the screen here is actually the adnexa and stuff from around one of the globes. So we've got our eyelids here opened up at one of the canthi, and we can see that the conjunctiva is all very thickened there. So the rest of the globes were relatively unremarkable grossly, and so the main lesion is in the conjunctiva. See here. All right. So subgross. Let's see here. All right, here we go. So here we have eyelid margin. We've got meibomian gland. We've got hair follicles here. And we can see the thickening here on the conjunctiva. And as we head out towards the third eyelid, we can see this really eosinophilic material expanding the conjunctiva there. And if we look at this piece here, here's a piece of third eyelid. We've got the gland here, the cartilage, and again, more of that big plaque thickening to the conjunctiva. All right, so again, third eyelid, got our cartilage, lots of inflammation here. You can, from the slow power, start to maybe pick out a little few lymphoid follicles, and then our gland, the third eyelid here, maybe a little bit inflamed, but otherwise not too bad. And so our infiltrate here, closer. More so. Oh, we can even go closer. Here we go. So we have lots of plasma cells here. So we have this nice little perinuclear clear zone and kind of eccentric nuclei. So lots and lots of plasma cells. It's very plasma cell rich inflammation. There are all smaller lymphocytes in here as well. And in some areas, we do start to get some neutrophils. And then this is all expanding the substantia propria, and included in here is this extracellular eosinophilic matrix that's acellular. Here, as we go to the surface, we can see conjunctival epithelium here, a little mildly hyperplastic and sometimes attenuated over this material. So this material here is consistent with fibrin deposition here, and it goes along with the disease process that was suspected clinically. And so this is Ligneous conjunctivitis, which is caused by a deficiency in plasminogen, which causes a breakdown in the pathway to get rid of the fibrin and start the healing process. And for it to proceed to granulation tissue and such forth. So without having the plasminogen, that doesn't happen. And so you get accumulations of the fibrin on surfaces that are prone to trauma, like the conjunctiva. It can be seen in other organ systems in the body, including like the oral cavity, like the kidneys, the respiratory tract, the GI tract, the reproductive tract, and the skin. So it can cause some systemic disease, although that didn't seem to be the case in this dog. And then as an incidental finding, because it is fun, in the left eye, as we're finishing up here, we found some nematode friends in the episclera here. So not a whole lot of inflammation associated, but you can see increased fibrosis. All right, here we go. See if we can. So we have eosinophilic cuticle. We've got these nice symmetrical ridges that are consistent around the edge here. We've got musculature, we've got reproductive organs, and we've got some microfilariae here. So these are features of onchocerciasis parasite, which we often see in the western U.S., California, Nevada, Utah. I believe this dog was from California. So that was just sort of a incidental finding for that eye to go along with the Ligneous conjunctivitis. It is kind of a rare condition. Doberman pinchers and Scottish Terriers, I think, have been the ones mainly affected. It's been reported in a Golden Retriever and a Yorkie as well. So just first time I've seen that lesion, so I thought it was pretty cool.
Sorry, I must have missed. What were the main clinical signs they described?
Bilateral,
Systemic signs?
no systemic signs, just bilateral symmetrical thickening of the conjunctiva.
Yeah, that's an interesting thing because that seems to be a very common scenario for us. We receive those samples that look like Ligneous conjunctivitis, and there's no obvious, or often there's no description of systemic disease. And if you read the, pathogenesis of the disease, I think the most problematic process is a glomerular kidney disease, because that material will accumulate in the glomerular. So kidney, renal insufficiency, it's usually what lead to these patients' demise. And we don't know if there's, it seems to have to be a disconnect between the periocular clinical signs and the systemic disease. Apparently, they don't seem to be necessarily sick by the time that we receive the sample. And I don't think we get enough follow-up to know what happens afterwards. But
yeah. I feel like, isn't it true, Jamie, that the reports that are in the literature, they don't have the same mutation that humans have, and sometimes often they don't find the mutation ever.
Yes.
So it's not really known what the mutation is in dogs.
Yeah, I think it hasn't. They've found some mutations, but not all dogs have that mutation and still have this lesion. So it's still a little bit nebulous on that.
Which is not all that surprising that it would be a heterogeneous kind of thing that can lead to the same clinical signs. But
makes you wonder if any plasminogen dysregulation or dysregulatory disease or state might lead to these lesions to happen, even though it's not like a primary plasminogen deficiency.
Yeah, and I think the interesting thing that I read is that even with this, they don't often see like thrombi in vessels, and so the breakdown process of fibrin thrombi has a different pathway as well, or a secondary pathway that can help break it down. So
if you want to see some really horrifying human eye pictures, just Google Ligneous conjunctivitis as a Google image search, and be horrified.
Yeah, sometimes you have to be very specific about putting a dog in.
Dog.
Otherwise, if there's a human correlate, you get surprised. Then
Do they sample any other tissues from this dog, like kidney or mucosa?
Not that I know of. And again, they said no systemic signs at time of diagnosis or even during the treatment, because sometimes it'll continue to progress even with some treatment.
all right.
All right. Next slide. All right. Next up is a 11-year-old Australian Shepherd mix, female spayed doggo. This is the left eye with the findings clinically of moderate diffuse edema, a deep stromal vascularization that went all the way around the globe. Had some axial superficial stain uptake, 3+ flare. They describe posterior synechia and iris bombay. Mature cataract in the lens, and there was either lens material protruding from or possibly granulomatous inflammatory debris is what they described clinically. It was glaucomatous. And the dog is also hypothyroid and anosonian. So we got the left globe. Here's our hemisection view with our cornea up here at the top. You can see our iris here. There's some white to tan material either lining the iris or within the anterior chamber. We've got some hemorrhage and some more tan material kind of back here in the posterior chamber and into the vitreous. It was possible that the retina might have been detached and kind of plastered up here. So a little bit of TAMA stuff here that we will take a look at with our globe. Right. So like in the gross picture, I got the cornea up here at the top. We can see that there is what was once like a white tan color grossly is now very purple here, and it's kind of in the base of the iris over here. And we got a little bit kind of lining the ciliary body over here. Here's our lens. So we can start to see a little bit of liquefaction of the lens fibers, so some cataract exchange, and some eosinophilic material and hemorrhage in the vitreous, and cupping, pretty big cup in our optic nerve as well. All right. All right, so got our cornea out here, a little bit of keratitis and vascularization coming in peripherally, and then we can look at our cellular infiltrate here. And what we start to see are sheets of round cells. That have a moderate amount of eosinophilic cytoplasm, pretty rounded oval nuclei. They're either finely stippled to densely stippled chromatin. We've got multinucleated cells in here. We've got pretty readily identifiable mitotic figures. Just kind of scroll around. Here's some more. Some of them are a little bit bizarre looking. And so this material is facing the base of the iris. It's also lining ciliary body plicae. Here's a nice, again, pleomorphic, very multinucleated giant cell here. And so we can see all that stuff in the anterior chamber as well. And here's some more. It's the same material on the other side as well. So they're got a neoplastic population of round cells. And with the pleomorphism, we had a high degree of suspicion of a histiocytic sarcoma. Elsewhere in the lens or in the globe, here's our lens. We've got our cataractus degeneration or more ganglion globules here. Go along with the cataract, we've got a lot of fibrin and hemorrhage in the vitreous, and there's a lot of necrotic debris, and there's a lot more cells here than you would expect with maybe just blood-associated leukocytes here. And I imagine that some of these are necrotic neoplastic cells in here as well. And our retina is fairly atrophied. There are some areas of necrosis. It's a little bit detached here. We've got some cells underneath it. We've lost our photoreceptor layer. And then we've got that cupping of the optic nerve head. So with a high degree of suspicion for histiocytic sarcoma, we offered a CD204 for histiocytes to confirm that diagnosis. You can see even the necrotic cells in the vitreous were positive. And then we have nice positive staining for the CD204, confirming histiocyte origin, and this is histiocytic sarcoma. So even our big multinucleated cells. Here's a nice one, a little alien crawling along the ciliary body here. All right, so histiocytic sarcoma can be hard to tell if these are primary ocular tumors or if they're metastatic disease. But either way, it's fairly bad news generally for the patient. Usually by the time that it's diagnosed in the eye, there's extensive systemic disease. So I think we've got an average survival time after diagnosis in the eye of about 3 months. So we suggest staging the patient, see if there's any other tumors elsewhere.
Did you mention the carpeting behavior in this one?
Yeah, the carpeting behavior is often something that we see with metastatic disease of neoplasia to the eye. So maybe that makes it a little bit more likely that it's metastatic in this case, instead of forming a big mass-like lesion in the globe. So, yep, I think that is it for me. I'll turn it over.
Dr. D was asking about the breed of that.
Oh, the breed.
Ligneous conjunctivitis case.
Oh, the Ligneous conjunctivitis breed was a Doberman Pinscher, male neutered, 4 years old.
All right. I'm Megan Kleinman's a staff pathologist, and I was the one who forgot to update the data on the first slide. Hello, everyone. So the first case today is, yeah, they were whispering about it. Anyway, I didn't notice. So anyway, it's not important. What is cool is this case. So let me make sure I have the right paper. Yes. So this is a 30-year-old saddlebred Paso Fino mare. This image is not this mare, and this is not Coplow's image. A partial citation of the paper that this image came from is here, and the full citation will appear on the next slide. I just didn't want to give away the diagnosis. So this image just depicts exophthalmia or exophthalmos in this horse, so sort of as a representative image. You can see that this eye, the right eye in this animal, is bulging slightly. And indeed, in our patient, it was a similar situation. The right eye had been exhibiting exophthalmos for about a year. There was exposure keratitis and decreased retropulsion, and ultrasound showed a mass in the retrobulbar space. And then the description of kind of how the surgery went is also very important to note for this case. So they say that there was hemorrhage during surgery, as expected. They already had a diagnosis in mind for this case, but we won't reveal it up front. Part of the mass was friable and unable to submit, and the surgery was a debulk and rapid closure. So it sounds like a challenging surgery with a lot of hemorrhage. So that is the stuff there for this case. We'll switch to the histopath, and I'm pretty much just going to show you the mass in the orbit. We basically had this mass submitted separate from the globe, and it looks pretty much the same throughout. So this was kind of like a tan mass, grossly, and then histologically it's pretty highly cellular. Let me find its edges. Its edges are pretty well demarcated. It's not really encapsulated, maybe a bit of a collagenous pseudocapsule or so, but pretty well demarcated, kind of like a lobular look from low magnification. And if we zoom in on the cells, this is a neoplasm. We find like the perfect field that I like the best. Very important. This one's fine. So these cells are actually kind of arranged in these little packets. So like packet, packet, packet. And then these little packets of cells are divided by these very delicate capillary sort of septae here. So little packets divided by septae. If we go in closer on what these cells look like, they're fairly large and polygonal. And they have, it's kind of maybe hard to see with the camera, but they have abundant cytoplasm that's very finely stippled, sort of like a granular cytoplasm. This appearance to a neoplasm, these packets divided by delicate fibrovascular septae or delicate capillary septae, is pretty characteristic of neuroendocrine tumors. Technically, you can't, make a definitive diagnosis, maybe just with this, but it's very highly suggestive. Let's put it like that. If we wanted to confirm it, which we haven't done in this case yet, we could run some immunohistochemistry, maybe a chromogranin A. But this is pretty characteristic neuroendocrine tumors. And then in the orbit of a horse, there is a specific diagnosis that one could make, and was indeed the diagnosis that they suspected clinically. And that is extra-adrenal paraganglioma. Extra-adrenal paraganglioma. So this is a diagnosis that happens in horses. It's been published in the paper that I'll refer you to in the next slide. Basically just referring to the suspected origin of this neuroendocrine tumor. It is associated with really severe hemorrhage in the orbit of these horses. The paper actually describes it as an expulsive hemorrhage. I feel like expulsive is never an adjective you want for intraoperative hemorrhage. So it can be really hemorrhagic, which is an issue. I'm kind of half looking while I'm talking for something else. Maybe, no, that's planned. Never mind. It's fine. That wasn't important. There's actually like a sarcocyst or two in these sections, but I forgot to detect where they were before coming to rounds. So maybe they were with the globe. So this tumor has been published like a case series of like 6 cases. And as such, I would say that its biologic behavior may be kind of up in the air. We don't have a whole lot of cases to characterize how it's going to behave, but at least based on the follow-up that they have for very limited case numbers, it's a slow-growing tumor, and even incomplete excision may get you a pretty good clinical result. I mean, there's been some horses with complications down the road, at least with an initial debulk, and there's spotty history in terms of actually doing necropsies and, like all sorts of things. So like it's a small case number, while there's maybe some evidence that it could be slow growing and a relatively good prognosis, I'd say like just be cautious because it's still small case numbers yet. And I can't find the sarcocystis, but it's not a big deal.
Can anyone in the audience or anyone else think of another equine orbital lesion that leads to a lot of bleeding during surgery?
Good point.
Possibly even more bleeding than they would expect with this.
Also in mind.
Equine orbital angiomatosis, which is probably not neoplastic, but I'm not sure. Weird vascular lesion where you get a proliferation of patent blood vessels that are kind of abnormal histologically, and that can lead to bleeding, both probably before surgery and during surgery, which is another one where it's like, oh my gosh, that's a lot of blood. Let's get out quick.
Yeah.
So anyway.
Yeah, that one, you might have a case history of a horse with like exophthalmia, and it kind of like worsens if the horse's head like drops, which is very interesting because it's basically just like these big like abnormal vascular spaces that can get kind of like engorged with blood. But yeah, good differential for the clinical presentation. So yeah, orbital tumors in general in horses are not very common, and this is not very common again, but it's been published. Here's the full citation. Keep in mind again that that image is not ours. It belongs to these guys here. Check out their publication. And that's it. That's all I had for this. Okay, so the last case, I think we have enough time for it, is a 7-year-old paint mare. And the horse presented for enucleation due to a non-visual right eye. The horse has a history over 6 months of the diagnosis, which I'll withhold for now. Otherwise, apparently healthy mare. And interestingly, they said that the other eye has no abnormalities at this time. Okay. So the gross hemisected view of this eye, we have a cloudy cornea. Interestingly, the anterior chamber is pretty narrow. So here's the iris, and here's the ciliary body. And so the anterior chamber would be up here, and there's barely any anterior chamber there. There's presumably some degree of synechia. You can see the iris kind of sticking to the cornea here, for example. And then the probably posterior iris, but certainly ciliary body surface especially, is coated with this kind of white film. And you can see maybe strands of this also kind of extending maybe into the vitreal space and things like that. So this interesting film is important. And then we have kind of a cloudy lens. And then we also have this subretinal bubble of sorts. This can be a common artifact during trimming of eyes. You can get bubbles trapped underneath the retina. And then especially horse eyes, the retina artifact attaches all over the place all day long. We can confirm or rule it out potentially histologically. So, all right. Oop. Wait, I keep forgetting. Okay. So here's the cornea up here, again, noting that very narrow anterior chamber. Probably some degree of synechia of the corpora nigra to the posterior cornea, although it's a little bit suspicious or a little bit not obvious in this plaintiff section in terms of being an actual real synechia. And then as we go to the ciliary body surface, you can see that there's this pink stuff lining the ciliary body plique. Sort of fuzzy pink stuff. Pretty significant. And maybe a little bit of fluffy pink stuff kind of extending into the vitreal space in the posterior chamber or so. And there's a little bit less of it along the posterior iris as well in this case, but mostly on the ciliary body surface. So let's take a look. So this is extracellular, kind of finely fibrillar, eosinophilic material, pretty tightly adhered to the ciliary body surface. And this is amyloid. So we have a really thick amyloid carpet along the ciliary body surface. And then if we look right next door, so the ciliary body epithelium is a little bit distorted, maybe kind of hyperplastic or so. But the non-pigmented layer is kind of on the top, and then the pigmented layer just beneath that, like you would expect. And in the non-pigmented layer, you can occasionally see these little linear, brightly eosinophilic bodies. So these are in Coplow referred to as Cooley bodies. You probably won't see them published as such. You may just see them called linear eosinophilic inclusions. So we have an amyloid carpet, especially over the ciliary body surface. We have linear eosinophilic inclusions in the non-pigmented ciliary body epithelium. And then the last thing that can kind of be part of this diagnosis, we can see lymphocytes and plasma cells sort of admixed with the epithelium here. And if we go into the stroma of the anterior uvea as well, we have some lymphocytes and plasma cells infiltrating the anterior uveal stroma. And so we have a lymphoplasmacytic anterior uveitis. So these three things, an amyloid carpet, especially ciliary body amyloidosis, lymphoplasmacytic anterior uveitis, and the linear eosinophilic inclusions are kind of the classic presentation of equine recurrent uveitis. So that's at least kind of how it is diagnosed currently. Basically, the amyloid carpet is what is kind of the key diagnostic feature, and then you may or may not see the linear eosinophilic inclusions, and you may or may not see an active uveitis in your enucleated globes. For whatever reason, some of these are probably chronically medically managed, so who knows if that impacts things a little bit. That said, it's worth noting that there may be some overlap between the amyloid carpet and like other diagnoses in horse eyes, like heterochromic iridocyclitis, which is a more recent thing that's been published. So we're kind of still like interested in looking into some of these things. Like maybe the amyloid carpet may not be as specific as we once thought, but at least currently, if you're being tested on it, for example, the key diagnostic features for ERU are the amyloid carpet plus or minus linear eosinophilic inclusions in the non-pigmented ciliary body epithelium, plus or minus lymphoplasmas like anterior uveitis. That's the classic. So this is a classic case as far as we're concerned. Some other kind of neat features in this eye. The anterior chamber was narrowed, and then if you look at the iridocorneal angle, you can still make out pectinate ligaments here, and then maybe where the trabecular meshwork or especially the uveoscleral meshwork would be, but it's quite narrow to collapsed in this case, along with the narrowing of the anterior chamber in general. Again, like maybe there's synechia, but I'm not necessarily convinced at this level. There's kind of like something on top of the corpora nigra here, maybe a fibrovascular membrane. Kind of suspicious that there's some degree of anterior synechia though. And then the same sort of thing with the angle on this side. To compare in terms of aqueous outflow for horses, we do have that orbital tumor horse here, which had much more of a normal, well-formed angle. We're going to orient it the same way. Consistency. Wait, this way. I am really used to having the cornea a certain way. All right. So here is an open and more normal horse angle. You can see the pectinate ligaments here, and you can see the trabecular meshwork. And horses have a really like extensive uveoscleral sort of meshwork. That's a little bit artifact pulling apart there. But trabecular meshwork, pectinate ligaments, a nice open angle, and you can see that our horse that we were just looking at, our ERU horse, has a very collapsed aqueous outflow pathway. This horse also had a cataract. You can see some mineralization in the cortex, even from low magnification, but we'll just kind of zoom along back to the back of the eye to take a look at some of that. Wait, that's the ciliary body. Here we go. There we go. So this optic nerve is interesting. The beams of collagen of lamina cribrosa are kind of not quite level with the choroid, to my mind. So maybe there's some subjective cupping. There's a lot of extra tissue on top of the lamina cribrosa. Horses sometimes get like this proliferative glial thing in the optic nerve head. I didn't necessarily call it in this case because there's some other changes that could be distorting the tissue in this area, but maybe some degree of optic nerve head atrophy. And then there's definitely retinal detachment for real. So we have this area where the retina is lifted, the neurosensory retina is lifted from the RPE. We have this high protein fluid in between the RPE and the neurosensory retina. So the presence of this fluid is already helpful to confirm that it was truly an in vivo detachment. You don't usually get stuff like that sneaking under the retina artifactually, not in significant amounts like that. You can see that the RPE is hypertrophied. This will be referred to as tombstoning by a lot of people. So you can see how these kind of look like a row of tombstones with how like plump and hypertrophied they are, which is also another indication that this is a true in vivo retinal detachment. And then if you look at the neurosensory retina itself, it's pretty atrophied in terms of the outer layers. So you have a thin outer nuclear layer and basically no photoreceptor segments to speak of. But what I thought was interesting is that there's also atrophy and kind of jumbling of the inner layers too. Maybe better to see here where it's a bit more of a flat mount. So we don't really have any retinal ganglion cells and probably not really much of an inner nuclear layer to speak of. Which is interesting to me and kind of suggests that maybe there was some degree of glaucoma in this horse, maybe preceding the retinal detachment at the site. And I blame it on like synechia and things like that in the anterior segment. So kind of a lot of extra things for this horse, some bonuses, I guess you could say, in terms of diagnosing the ERU as the main thing. And then the last thing that's kind of cute to show since we have like a minute. Wait for it. Maybe the other side is better. There we go. This is totally not important, but I'll show it to you anyway so that you know that it exists, especially if you're reading horse globes in the future. So here's the choroid, here's the RPE, and then in the sclera, kind of like just posterior to the choroid, typically like kind of inner sclera. In the posterior sclera, we see these multifocal areas of mineralization. And this is a really common finding in older horses, and it's in clinically incidental finding. So it's presumed age-related degenerative change. If you see it in your horse globes, don't worry. And that's the only reason why I'm showing it to you, just to say, here it is, don't worry. And that's it. That's all the things in this horse. There were a lot of things. I think there was maybe some minor corneal stuff. But the main diagnosis and reason why I was showing it is because it's a pretty classic case of equine recurrent uveitis. So that's it. That's all I have to say. If there aren't any
I
questions.
want to acknowledge some interesting conversations in the comments here about relationship of ERU and tics or
Ooh, yeah.
uveitis,
That's actually an interesting
being
discussion.
different processes or being variations of, or being a variation of ERU. Dr.
Ooh.
Bentley, that's what she thinks is a subset of ERU, and Ryan chimed in, potentially a more acute one. We don't have time for that today, but just something for you guys to chew there before we come back in 2 weeks.
Yeah, basically this stuff is kind of the superficial stuff that's currently like, you know, the ideas, but there may be more like subtleties to it and overlap between some of these conditions than, you know, is thought about up front. So just something to like, yeah, as Leandra says, just something to think about. Cool.
Thanks,
All
everyone.
Start recording.
Wait.
Go to Google Chrome.
This button? This button?
Mhm.
This button?